All right. Do we have the right screen up there?
Yep.
Where's all this kind of goes? Okay. Well, welcome to the snow edition of CBT Family Echo. Hopefully you guys are all nice and warm, have a hot beverage, and we'll go through a little didactic here. So today's topic is going to be CBT for thought disorder. And this is one of it's less common positive symptoms. Not that it's less common, it does occur with some frequency with psychosis, but it's talked about a whole lot less. And there's not as much in the literature that addresses this in manuals or other places, but it can be just as much a challenge if you're working with someone who is experiencing a formal thought disorder or disorganized thinking. The other interesting note is that in the literature, it's often an exclusion criteria for a CBT study. So there's not as much research as we'd like on this, but I did find a couple of really good articles, at least one really good article from a CBT standpoint, check the manuals. And the good news is that the model fits pretty well, even with thought disorder. And so I'll kind of walk us through some of that, and then we'll kind of go from there. Okay, so what do we mean by formal thought disorder? It's kind of a rather clinical term. But it's sort of misnamed. We don't know, we can't see exactly what a person is thinking. We can observe it based upon speech patterns and communication. So it's really has more to do with thought language communication rather than a thought disorder, although formal thought disorder is the term that's often used. And when they've tried to categorize it in terms of phenomenology, there's lots of different factor analyses, but basically they kind of fall into two big categories, positive and negative. So positive thought disorder, if you want to call it that, is really about pressure, kind of speed to some extent, and drift from content or main point. And so I try to do a little visual graphic there just to give you a sense. And if you really want to get into the nitty gritty of it, the TLC measure by Andreasen that I have referenced in the back, and I can send you a copy, has like definitions of all the nuances of different parts of the formal thought disorder. But I'm just going to talk about kind of the first category, positive, and the kind of the drift from the center or drift from a main point. So if the center of the bullseye to the right there is the main point, if a person's talking around the point, that's called circumstantial thinking. All right. And that's not necessarily clinical. It happens with some regularity in regular populations. Somebody that's kind of long-winded, adds unnecessary details, doesn't get to the point. That's circumstantial thinking, looping around there. As the thought drifts further, one category is called tangential thinking or tangentiality. And this is really where a person starts in a topic area, drifts to another topic area, and then builds off of that topic area, and it can kind of go in different directions. All right. So I'm going to go to the store to get some medicine to sleep. Oh, sleeping is great in the Alps. The Alps are a fun place to ski. And then you kind of go in a route that way. And so you can kind of get into a tangent and into other tangents. Now, one way to check and see how disconnected the person is if you ask them, hey, what did we originally start with? What was the original topic? If they can come back to that topic, then there's less of a disconnection there. So they're tangential and they're riffing in different directions, but they can come back. So that's next on the level of the continuum, if we think about thought disorders on a continuum. And then at the further end of the continuum is loose associations or derailment, illogical. And in my slide there, I have it way off to the side. So I'm off to the store to get medicine for sleep. Sleep is demons. Demons are mountains. Mountains are skies. Cries, and they fly. Why, so what's happening is that my speech goes so far off, and I ask you, where did we start? The person's unable to get back to it, whatever the main content point is. So there's further and further disconnection. So it's one way that's helped me to kind of think about thought disorder just phenomenologically. On the negative side, essentially it boils down to poverty of speech, which essentially means when the person has very little response. You often see it with negative symptoms. What are you going to do today? Store, What are you going to go to the store for? No, medicine. So there's less access to information. They're not providing as much information, things like that. Now, what we know about the positive and negative, the positive formal thought disorders, less persistent. It seems to be influenced by state factors or things in your person's circumstance. The negative thought disorder tends to be a little bit more stable over time. All right, so that's a little bit about the phenomenology. Prevalence, how often does this happen? So in quote unquote normal population, 6% will have certainly circumstantiality. We can all go off on tangents at different times. I do it quite often. So it does happen. If we look at mixed samples and individuals with schizophrenia, we can get up to 80% of folks showing signs of this more formal thought disorder, more disconnected variations of it. And when they look at how often does this interfere with activities, it's about a fourth, 27% there. So a couple notes with that. When we think about it, it's so many people can have presence of thought disorder, fewer, but it's still a substantial percentage will have thought disorder that interferes. But even when it interferes, it's not there continuously typically. All right. There's usually periods of clarity, even in the most extreme cases. All right. A couple of diagnostic features. Mania, the quality of it when you look at group comparisons tend to be greater quantity of speech, more coherent, relatively speaking, more playful, combinatory sort of thinking. So, there's a dog, looks like it's got wings, it's a flying dog, kind of playful kinds of things. That sort of thinking is more characteristic of manic style, whereas schizophrenia, there's more missing information reference. It's more kind of stilted, idiosyncratic, harder to link up connections, things like that. Just a quick note on substance use, looking at cannabis abuse predicted worse formal thought disorder at a 5.5-year follow-up. That was just one clearer statistic that I could present. But the basic idea that if you add substances to an individual who's already having some disorganized thinking, it can certainly further exacerbate it. Okay, a couple other features. Therapeutic Alliance. In general, as folks have more formal thought disorder, when clinicians are asked to rate Alliance, they tend to rate lower Alliance. And it kind of makes sense, right? Because it's harder to make a connection, try to figure out what's going on. It's just difficult. And so there's a strain on the therapeutic relationship. And when there is formal thought disorder, clinicians are often more likely to see the client as sealing over. And what that means is that when folks seal over in their recovery, they don't acknowledge part of their psychotic experience. They just sort of, oh, that was in the past. Don't have to acknowledge it. I'm just going about my day. And so that, as far as a recovery style, it's sort of associated with that. Now, the only reason I mention it is that the take-home message, as with all of psychosis, but in particular with formal thought disorder, is that the Alliance is going to feel challenging, even more challenging. That's why even more important to kind of find some strategies, find some ways to kind of make that connection best you can. And we'll talk about a variety of ways, but empathy is always the key, with simple reflections, gentle exploration, asking permission, a lot of things that we do in general CBT. The other thing that's interesting, I gave this presentation to another team yesterday, and what they said was that often with formal thought disorder, it can be there, but it's often not talked about as much, right? We talk about hallucinations or there's a paranoid thought, but the act of communication and the difficulties is sometimes not even addressed very much in session. So this is a way to have a context to do that. All right, so this is from Palmier and Claw's article, just some questions to ask to get a sense of a person's awareness of their disorganized thinking. This presumes that they have some awareness, which is not always the case. But there's some good questions in here, just generally, are there times you find it hard to communicate? Do people ever say it's hard to follow your communication? Have you noticed anything that makes it easier to communicate? Or when you notice that your communication is off, how do you feel? How do you cope with situations when you feel like your communication is off? And again, that presumes a level of awareness of it. Now, again, if there's minimal response to this, couple of options that you can do. Try to make your questions more simple, like yes, no kind of questions, to get at information a little bit more, and looking for just general themes. And then the other piece too is often to seek input from family. What have they been able to grasp and understand based upon the person's how they're communicating, what themes have they picked up on, or what strategies have they found, or times of the day, or whatever it may be, that helps the individual communicate a little bit better. All right, so we'll conduct an assessment and then we'll develop a formulation. This is a common formulation for at least one type of thought disorder that happens. And the pattern is often that something of emotional distress is kind of activating to kind of disrupt our thought process a bit, which leads to the disorganized speech, which can then lead to appraisals like I'm damaged, or others will think I'm stupid, or there could be a delusional reference like somebody's controlling my thoughts and that's why I can't communicate, leading to more distress. The common safety behaviors are hypervigilance, like pay attention to what I'm saying, or avoidance, or substance use, the other kind of common things that happen. And again, the typical pattern is short-term reduction in stress, but then increased distress over time. All right, so that's the general sort of formulation pattern. The treatment approach will build off of this formulation. So if you're able to kind of generate that based on your assessment, getting a sense of what's happening there, and then try to see, okay, where could I potentially intervene? Some things that are recommended, obviously the relationship is key. So whatever you can do to enhance the alliance is really important. Remember to, you can always have shorter sessions, more frequent, take breaks, look for opportunities to offer feedback or take breaks. If you're going to set an agenda, which you should, try to keep it very limited, some structure to it, but very limited. Try to be as clear as you can with take-home messages, things like that. One interesting note when reviewing, and we always do review in CBT, in the START model, that's the R part. One of the things, if the client's willing to record, that the author suggested is to listen to kind of the summary part of the tape, the whole tape if they have time, but if the client's willing to listen to the summary sections of it, to then listen to it together rather than the therapist leading the review, let them sort of review, listen to the audio and kind of provide some feedback. They found that to be helpful kind of clinically. And again, anecdotally, there's not big research studies on that, but that's what they kind of recommended. Feedback as a change strategy. And so this is early on in sessions, getting permission early to interrupt so that you have permission and kind of this collaboration to look at communication, to have an agreement that, is it okay if we periodically take time to just pause and look at what's happening? I've had a couple of clients that I've worked with in this way. And usually after you've developed a bit of a relationship, they're pretty open to that. Do you mind if we just stop for a second? And I lost track where I'm wondering where we're at. I'm a little confused and I can put it on myself a little bit, but just getting that permission and just request, like, I wonder if it would be okay if either one of us at any point could just sort of stop the session and just make sure we're clear and understand each other. Collaboration is essential because you don't want it to be punitive, like, stop, I don't know what you're saying, you don't want to do it in that kind of way. More collaborative, obviously, as our general approach is. I'm wondering what's happening right now in this moment. I wonder if we could look at it. You could also do a buzzer system, raise your hand or hit a buzzer if you have one. You can do that if you want something a bit more concrete. Just again, to provide that context, to use that moment to kind of look at what's happening. And if appropriate, this is where the curious questions come in. Like, can you help me? How did you get from here to here? Just curious. You mentioned being a bit frazzled and then you lost your keys and then you were saying the devil was doing this to you. I'm just wondering how you got from this to this. And that was kind of a scenario I'd run into with one of the clients I worked with. So that's a potential strategy. Permission, use feedback as a strategy. Again, I mentioned earlier that emotional salience is a factor that can, really rev things up a bit, where there's more distress. And so you can do this in a couple ways. In session, if you're wondering about this, you can just sort of assess when you're talking neutral subjects, neutral topics, how are they doing? And then talk about something with a little bit more distress, family's bothering me or work is bothering me, whatever. Does their speech get more disorganized when the emotional topics are more enhanced? And that's just sort of an in-session assessment thing you can do. If that's the case, and it often is, back to our emotion regulation strategies. Val talks about a calming self-soothing kit, developing some strategies that can be used in the moment and then just more regularly too, to kind of keep that activation level lower. And this is a place where, family and workplaces can be really helpful, in terms of identifying hot situations and ways to manage it. One of our counselors in another agency was working with an individual who was having, delusional thoughts at work that was a bit disruptive. And the counselor worked very skillfully to identify two things. One was a strategy, a self-soothing strategy, somebody that kind of was a carver, carved a wood object that became a self-soothing object that he could take to work. And so that was helpful from a self-soothing standpoint. And then also worked with the client to identify who was the trusted person at work to talk to when things got upsetting or a bit confused before doing anything else. And so there was a two-part plan in the work situation that kind of helped. The client had a way to self-soothe and a person to go to kind of help check with communication. All right, and that was quite helpful. You could do the same thing with family members. Cognitive restructuring, and a couple things. One, normalizing is always helpful to do. Quite frankly, any of us at any time could get a bit flustered. I mean, I've certainly had times recently where I'm like, can't remember this person's name, or I wanted to say something that I know quite clearly and I'm just sort of revved up and I can't think of it. When we're stressed, these things kind of happen. And so I think sharing those normalizing experiences can be helpful. And then, to create a space to then talk about it. And then you can kind of begin to look at the common cognitions that go with it. And they can be the whole category of social anxiety kind of concerns, which you can work with in cognitive restructuring. Or there could be more of a delusional or a voice hearing component to it, which you would then, kind of normalize and then explore a little bit. A client of mine came in for a session and was much more disorganized than usual. And we took some time to just sort of listen and kind of understand what was going on. And what happened essentially was that her daughter had called in the middle of the night, kept her up all night. And then that kind of flashed her back to some previous delusional thoughts that she had about like social services coming in, going to arrest her, some thoughts like that. She's rather disorganized. So we kind of slowly walked through it. And then we did a stress bucket and just said, well, I wonder what was going on, because we had done a stress bucket a few sessions ago. And by the end of the stress bucket, she's like, oh yeah, I've got all this stress going on. That kind of makes some sense. And she had an aha moment, and then it kind of settled her right down. And then her thinking became a bit more clear at that point. So part of it, I mean, part of it's a strategy, but part of it's just the relationship, normalizing and helping them understand where some of this may be coming from. And by doing that, just the relationship itself can sometimes kind of calm it. All right. So that persistent, patient kindness over time can be quite helpful. All right. And then the other issue is maintenance behaviors. Again, avoidance is a big one with all of our symptoms, but particularly, with formal thought disorder in this kind of situation. One of the things I wanted to mention, interesting perspective, we often will think about poverty of speech as related to an individual factor. So the psychosis is shutting down the thought content and so forth. Another way to think about it is that it could be related to the environment, right? So the individual struggles to communicate, family and others humor them, they don't really answer their questions. And as a result, the client, the issues aren't addressed, needs aren't met, and they're not guided to better communication. And so then as a result of that, there's a kind of demoralization that happens, like, well, I'm not getting any response. And so then the poor communication is partly out of the poverty of responsiveness of the environment around them. All right. And so that can become kind of a cycle. And this is, again, where it's really helpful to bring in family, workers, other things to enrich environments. And of course, with this, we want to address substance use, hypervigilance, if that's a factor, like I'm really worried about what I'm saying and how I say it. You can do reality testing. This is also a place where detached mindfulness strategy could be quite helpful. Just, notice what comes up, not react to it, and sort of let it pass, those kinds of strategies. One final little bit, if there's really severe speech where there's catatonia or no speech at all, and this came from early work in the 90s on pre-therapy, and this were folks who were either catatonic or not very responsive. And what I thought was really interesting about it is that we talk about doing reflections. When someone says something, you reflect back what you hear. And from this model, they talk about contact functions, what we need to do to be in contact with our world, and that you could be that sort of reality contact for the person by reflecting behaviors or things that you observe. All right. So in the world, if a person's non-responsive, you could reflect back, you are sitting, the lights are flickering, it's snowing outside, I'm just observing that, And so if the person, and you just see if they respond to any of those sort of reflections, if you will, about what's happening concretely in the environment. So you're providing that contact for them in that way. Affective content can be awareness of moods and feelings, like, I notice there are tears in your eyes. I wonder if you're sad. You look angry, your jaw looks tight, things like that. So that, again, very basic, but just observing and reflecting back in a gentle and kind way. And certainly if there is some limited speech, you can repeat that back, just as we would do in any of our other kind of reflections. You can do body reflections, describing where the person's arm is in the air or jaw, just like I mentioned before. And they also mentioned this thing called reiterative reflection. So if in some of these reflections there is some responsiveness, you can kind of come back to that and see if there's some connection you can continue to make by reflecting upon that piece. So again, this is for more severe situations. These are situations when I worked inpatient where I would use some of this kind of stuff when the person was catatonic, frozen, not really doing much stuff. Less likely to see probably in your outpatient practice, but still useful to kind of have just kind of conceptually, I think. All right, so summary, it's all about the relationship, and then keeping in mind that formal thought disorder is something you can talk about. Develop a formulation around it like we do other things, looking at activating factors, a special emotional salience, and then what maintains it. Use feedback as a strategy. Address those cognitions, again, with a lot of normalization and kindness and patience. Just be aware it's challenging, but can be done. All right. And bring in the family, if there are ways to involve them and helping the communication, either lowering the emotional expression at home or just improving communication. It's a real solid way to do it. Okay, that's all I got. References are in the back, and I'm happy to send any of the references that you want.